We will now begin with the podium presentation session. We have an engaging lineup of presentations ahead, accompanied by insightful discussions from our esteemed judges. Kindly note that we will not be disclosing the affiliation of the candidates. I also request the audience to kindly comply. Our judges for the day are Dr. Manjunath Prabhu, Senior Consultant Anesthesiologist, Brunei, and ex-HOD at KMC Manipal. Dr. Satyajit Karan, Senior Consultant Anesthesiologist and Faculty at Kanachur Medical College, who served as a HOD at Srinivas Hospital, Mangalore, and was also an ex-staff at KMC Manipal. Dr. Shripada G. Mehendale, Professor and HOD of Shema Hospital, Mangalore. We welcome you all and are privileged to have you here. Presenters, kindly note, you are provided 7 minutes for the presentation and 2 minutes for your Q&A session with the judges. The timer will turn red at the 6-minute mark. Kindly adhere to the time limit. With the 7 plus 2 minutes duration in mind, let us now begin with our first presenter. I invite Dr. Neetu to the stage. Dr. Neetu, you can begin your presentation.
Good afternoon to all. This is an observational study to determine acromio-axillo-suprasternal notch index as a screening test to predict difficult laryngoscopy. Unanticipated difficult airway may have negative outcomes like death, cardiopulmonary arrest, brain damage, airway injuries, and even dental damage. The primary objective of assessing the airway is to detect potential problem during airway management and to formulate a contingency plan. Acromio-axillo-suprasternal notch index, a relatively new test based on surface landmarks, have been suggested to reliably predict difficult visualization of the larynx by Mohammad R. Kamran Manish. It was developed based on the hypothesis that patients with a neck which is deep-seated in the chest was found to have difficult laryngoscopy. So to measure AASI, patient will be in supine position with hands by the side of the body. We take the line A from the acromion process to the superior part of the axilla and a line B which will be perpendicular to the line A from the suprasternal notch. This will intersect the line A. The part of line A above the intersection point is called the line C. So in AASI, we take a ratio between line C and line A. There have been many studies trying to figure out a cutoff value for AASI to predict difficult laryngoscopy, but none to identify difficult intubation. Hence, we had conducted this study. The aim of the study is to determine the accuracy of acromio-axillo-suprasternal notch index as a screening test to predict difficult laryngoscopy and difficult intubation. Primary objective being to determine the cutoff value of acromio-axillo-suprasternal notch index with the highest sensitivity and specificity to predict difficult laryngoscopy. Secondary objectives being to determine the cutoff value of acromio-axillo-suprasternal notch index with the highest sensitivity and specificity to predict difficult intubation, and to compare the predictive value of 7 anatomical indices to identify difficult laryngoscopy. These being modified Mallampati score, sternomental distance, thyromental distance, ratio of height to thyromental distance, upper lip bite test, neck circumference, and AASI. This was a single-centered prospective observational study started after obtaining approval from the Departmental Dissertation Committee, Institutional Ethics Committee, and after registration with the Clinical Trial Registry of India. Informed consent was taken from all 140 patients included in the trial. Patients included belonged to the age group between 18 to 65 years, belonging to either gender, posted for elective surgery under general anesthesia with ASA physical status 1 or 2, with primary airway plan being oral endotracheal intubation with direct laryngoscopy without the use of adjuncts. Patients excluded were those having anatomical abnormalities like limitation to the temporomandibular joint, atlanto-axial joint, oral tumors or maxillofacial tumors. Patients who have underwent recent head and neck surgeries, pregnant women, edentulous patients were also excluded. If the patient required a rapid sequence intubation and if the BMI was more than 35 kg per meter square were also excluded. On the day prior to the surgery, preoperative airway assessments were done. This included the modified Mallampati, sternomental distance, thyromental distance, neck circumference, upper lip bite test, and acromio-axillo-suprasternal notch index. Demographic data such as age, height, weight, BMI, ASA physical status, comorbidities were also noted. Written informed consent was taken from all patients. On the day of surgery, patients were shifted to the operating room. Monitors were attached and baseline heart rate, blood pressure, and saturation were noted. A freely flowing IV access was secured. IV fluid infusion was started. Patient's head was placed on a standard pillow with a height of 7 centimeters in sniffing position, and patient was pre-oxygenated with 100% oxygen for 3 minutes before the induction of anesthesia. All patients received analgesic fentanyl 2 micrograms per kilogram IV and propofol 2 milligrams per kg IV to achieve loss of verbal response. After confirming successful bag and mask ventilation, non-depolarizing muscle relaxant was used as per the choice of the anesthesiologist. Direct laryngoscopy was performed using an appropriate size Macintosh laryngoscope blade at least 3 minutes after injecting the muscle relaxant by an anesthesiologist with at least 2 years of experience. The laryngeal view was graded according to the Cormack-Lehane grading system, and parameters of intubation difficulty scale were noted. So coming to the results, figure 2, ROC curve for ASI to predict difficult laryngoscopy was plotted. Area under the curve was found to be 0.88, and the best cutoff to predict difficult laryngoscopy was found to be more than 0.573, with a sensitivity of 78.6% and specificity of 80.2%. Figure 3, ROC curve for ASI to predict difficult intubation was plotted, and area under the curve was found to be 0.89, with the best cutoff to predict difficult intubation as 0.609, with a sensitivity of 88.9% and specificity of 89.3%. Here is a comparison table between the various airway predictors. ASI was found to have the highest negative predictive value, and modified Mallampati had highest sensitivity and positive predictive value, while it had the least specificity and negative predictive value. Upper lip bite test was found to have the highest specificity. Upon further analysis of the intubation characteristics with patient more than ASI of 0.57, that is 36 patients out of the 140 patients studied, we found that stillet was used as an adjunct in 15 out of the 36 patients. Additional laryngeal pressure was required in 17 out of the 36 patients, and video laryngoscope and excessive upward force of laryngoscope was required in 3 out of 36 patients. From this, we can opine that in the patients who have anticipated difficult laryngoscopy, as predicted by ASI more than 0.57, the use of stillet and laryngeal pressure can be the first-line rescue if faced with difficulty during intubation. So, I would like to conclude that the cutoff with the highest sensitivity and specificity for ASI to predict difficult laryngoscopy and intubation is 0.57 and 0.61 respectively. And ASI had moderate sensitivity and specificity and highest negative predictive value as compared to other anatomical indices to predict difficult laryngoscopy and intubation. These are my references.
Yeah, Dr. Neetu, that was a brisk presentation of a big topic.
Yes, sir.
I have a few doubts about this because the sample size. You not mentioned about the calculation of required sample and the basis of the calculation.
Yes, sir. So we calculate the sample size based on a previous literature study available. So based on that, we had calculated, in that study, the prevalence of difficult intubation was 0.2. So based on that, we had calculated and we had obtained a sample size of 140, sir.
Did you define the parameters, very important parameters, that is difficult laryngoscopy and difficult intubation in your study?
So I did not.
Basic stuff in the study, that is difficult laryngoscopy and difficult intubation, had to be defined.
Yes, sir.
And it is subjective to the operator's experience.
Yes, sir.
And there's 2 years of experience, whether it is just getting into the anesthesiology or after qualifying as an anesthesiologist?
2 years of qualified anesthesiology practice.
Qualified, okay. And working definitions?
Yes, sir. So we had taken, based on Cormack-Lehane grading, grade 3 and 4 were considered for...
It was not mentioned in the presentation.
Yes, sir.
The other thing is, you're talking about laryngoscopy. When you're looking at the quality of laryngoscopy, I used different neuromuscular blockade agents depending on the choices of particular anesthesiologist. whether you achieved the same level of blockade when you did your scopy, because it was all timed. How did you achieve the uniformity on the level of blockade that you have, the relaxation that you have? It's
Sir,
critical for a scopy, right?
We had waited for a minute, 3 minutes after administration of neuromuscular blocking agent prior to before proceeding with intubation. Sir.
And that's what I'm saying. There should have been some sort of a monitoring of neuromuscular blockade. Probably that would have given an objectivity rather than just a time framed one.
Okay, sir.
Something which I thought might have been a little more stronger. And what made you think that this is a better indicator than the other ones?
So other inter-observer variation was more compared when we are using modified Malambati, upper lip bite test and all. Inter-observer variance was more. This was more objective kind of measurement. So and also we wanted to find a value that can help us predict difficult intubation, because multiple times difficult laryngoscopy has been we can predict, and with EC laryngoscopy also we end up facing difficult intubation. So we wanted to find a predictor to help us predict difficult intubation as well.
How do you think this ratio tells you about the scopy visualization, how it's going to be better or not? What's the scientific basis for that? So
when this INDIS was introduced, the concept was the neck, if it was deeper into the chest, the possibility of difficult intubation was considered. So we wanted to see whether it is relating.
Okay.
Can one single index predict difficult laryngoscopy or intubation?
So literature is saying multiple predictors will usually be a higher, more sensitive than using a single predictor.
Thank you all for the engaging session. I now invite the second presenter, Dr. Pramatesh, to take the stage.
Good afternoon, everyone. I'll be talking about my paper, which is comparison between dexmedetomidine and fentanyl as adjuvants to 0.5% ropivacaine in ultrasound-guided infraclavicular brachial plexus block. General anesthesia was mostly the primary method that was used for upper limb surgeries previously, but now with recent advances, we use regional anesthesia more often. And USG-guided brachial plexus block is commonly employed for this. Talking about the drugs I've used for the study, it's ropivacaine, which is a propyl analog of bupivacaine, which shares similar potency with a longer duration of action and reduced cardiac and CNS toxicity. It is a long-acting amide-type local anesthetic. It blocks nerve signals by inhibiting sodium channel. It's slow in onset with a long-lasting pain relief, and it's available in injectable forms. And its side effects, it can cause dizziness and hypertension. Dexmedetomidine, which is an alpha-2 adrenergic receptor agonist, provides sedative, anxiolytic, analgesic, and sympatholytic effects, prolonging analgesia by inhibiting norepinephrine release and hyperpolarizing neurons. It's commonly used for sedation, perioperative analgesia, adjuvants in regional anesthesia. It has minimal respiratory depression compared to opioids. It causes bradycardia, hypotension, and transient dry mouth. Fentanyl is a synthetic mu-opioid receptor agonist, is known to improve duration of sensory and motor blockade in brachial plexus. It causes respiratory depression, nausea, vomiting, constipation, and sedation. The investigation was done to find out which one's a better adjuvant to ropivacaine in infraclavicular brachial plexus block. The aim to evaluate and compare the effectiveness of dexmed and fentanyl as adjuvants to 0.5% ropivacaine in USG-guided brachial plexus block for upper limb surgeries such as elbow, forearm, and hand. The primary objectives being onset of sensory and motor blockade, duration of sensory and motor blockade, while secondary objectives were intraoperative hemodynamic changes or any adverse effects because of the block. Methodology, it was a prospective randomized comparative study which was done among 32 patients who were undergoing upper limb surgeries divided into two groups, Group D and Group F respectively for dexmedetomidine and fentanyl. Inclusion criteria included patients of either sex between the age of 21 to 60 years, patients belonging to ASA 1 and 2, with a weight range of 50 to 80 kgs and a normal BMI. Exclusion criteria was refusal for the study, coagulopathies or patients on any anticoagulants, pre-existing neuropathy involving brachial plexus, any localized skin infections at the site of the block, any hypersensitivity to local anesthetics. Preoperatively, the patient was evaluated and an informed consent was obtained. Routine investigations were done. Vital signs were recorded. 6 hours NPO status was ensured. And in the operating room, 18-gauge IV access was secured and standard monitors were attached. Intravenous fluids was administered at a rate of 1 to 2 ml per kg. Patients were positioned in supine. After sterile preparation, an ultrasound-guided block was performed by placing a probe over the middle third of the clavicle to identify the axillary artery and brachial plexus cords in the costoclavicular space. Using an in-plane lateral to medial approach, the block needle was advanced and the study drugs were injected around the 3 cords. The drug dosages were for group D, 1 mic per kg of dexmedetomidine with 30 ml of 0.5% ropivacaine. And in group F, it was 1 mic per kg of fentanyl with 30 ml of 0.5% ropivacaine. Coming to the statistical analysis and results, the demographic characters did not show much of a difference. Patients were approximately in the same age group. There was almost an equal distribution in gender, almost all of them belonging to ASA1 and 2, and duration of surgery being approximately the same. There were no significant differences between the groups. The onset and duration of the block. In group D, the onset of the sensory block was faster. And this was a significant finding of around 12.5 plus or minus 2.3 minutes. And the onset of motor blockade was also faster comparatively. The duration of sensory blockade is where we had the maximum amount of difference. We had 810 minutes plus or minus 50 for dexmedetomidine, while it was around 650 for fentanyl. Even the duration of motor blockade was similar, 780 and 620. So group D demonstrated a significantly faster onset and a longer duration of both sensory and motor blocks compared to group F. Coming to the hemodynamic parameters, as you can see, there was a pronounced, I wouldn't call it bradycardia, but there was a dip in the heart rate with dexmedetomidine, but none of this was clinically significant or statistically significant. BP stayed similar in both the groups. Coming to the adverse effects, group F had 1 case which presented with nausea and vomiting, and group dexmedetomidine had 1 episode of bradycardia and hypotension, but none of these were significant statistically. Discussion. The present study was carried out to compare the onset time and duration of both sensory and motor blockade among the 2 groups. Results regarding the sensory block during the present study showed that it was significantly faster in dexmed with a longer duration in dexmedetomidine. And both sensory and motor, Kathuria et al. Compared dexmedetomidine and fentanyl as adjuvants to ropivacaine in supraclavicular brachial plexus block, and they showed similar results to this study that I've done. The present study found no significant differences in hemodynamic parameters and adverse effects between dexmed and fentanyl. Conclusion, it significantly prolongs the duration of motor blockade and sensory blockade in group D. It facilitates a faster onset of the block, allowing for a quicker surgical readiness. Its safety profile is also favorable with minimal side effects which were observed. No sedation or bradycardia. These attributes make dexmedetomidine a more effective and a reliable adjuvant compared to fentanyl. Limitations of my study were that the sample size was small. It was a single center study that does not reflect a broader patient population. Only 1 dose of each adjuvant was tested, so there was no exploration of any optimal dosing. And I also used I had patients of ASA 1 and 2 only, limiting the applicability to higher risk groups. These are the references. Thank you.
Okay, Pratish, good presentation. I just want to know, sample size, you was said it is a small sample size or something like that. How did you come to that conclusion?
Sir, because it's only checked in about 32 patients, but most of my studies said that it was clinically significant when they took a patient population of above 50 patients. But this was taken into consideration only after the fact that we had a baseline value of 0.5, p-value of 0.05%, in the previous studies with smaller sample sizes. So that's why I chose 32 for mine.
Okay, that is basically you are talking, which is your primary objective here now?
My primary objective is the onset and duration of sensory and motor blockade.
Sensory, all four you are taking.
Yes, my primary objective is both onset and duration of sensory and motor blockade.
Okay. What about sensory block? How did you check? What is your, when do you call it as a already worn off?
Okay, so sensory blockade I checked with the pinprick test.
Where?
At all the regions covering the 3 chords. So it went from proximal to distal, where I checked for all from C5 to T1 basically, all the dermatomes covering them. At an interval of 1 minute to get to know the onset of sensory, and this was done only to prick and not to touch. So when the patient lost sensation to prick is when I considered the onset of sensory blockade.
Okay, C5 also you checked. And what about the specific nerve? Sometimes because when you go to the brachial plexus, as you go down, some nerves will miss. So any specific nerve areas you have checked?
Mostly what I covered was the musculocutaneous, medial, ulnar, radial, and the axillary for the deltoid. But I know that this block particularly has a sparing on the medial side of the arm, which is covered by the intercostobrachial. That was the only concern, but otherwise the rest of them were just checked with pinprick.
The observer who is checking all this thing,
yes.
Was he blinded for the medication that was used?
Yes, sir. It was single-blinded study. It wasn't double-blinded. I haven't mentioned it.
That was not mentioned at all.
I haven't mentioned it. So, yeah.
Because otherwise there is going to be a bias on the whole process.
Yes.
No? That's one thing. The second thing that I wanted to ask, having used ultrasound,
yes.
Do you think you had to use that big a volume?
No, sir, but I just wanted to see the duration, if there is any difference with a larger volume, because there are studies with smaller volumes, because USG guided, usually you have a smaller volume, but I wanted effective analgesia later on.
No, it effectively defeats the purpose of using an ultrasound and adjunct.
True.
If you use such a large volume of a local anesthetic.
Yes.
So it doesn't take us anywhere.
Yes.
Isn't it?
Yes.
All right, we are run out of time.
Yes,
So it's a good presentation. Thank you.
thank you, sir.
Thank you all for the informative session. I now invite our third presenter, Dr. Gokul, to take the stage.
Good afternoon to one and all. So my title, A Correlation of Trends in Base Deficit in Critically Ill Patients with Their Survival and Hospital Stay, an observational study. So a metabolic acidosis is commonly encountered in intensive care unit. So the severity is linked to the linked with the greater mortality. So a patient with a metabolic acidosis are twice as likely to die as without it. The extent of this derangement and the time taken to normalize these parameters may predict the outcome of the patient's duration of hospital stay and mortality. However, this is not well investigated. This study was aimed to evaluate this hypothesis and close this knowledge gap. So my primary objectives, a correlation of time to normalization of base deficit to hospital mortality. It is where correlation of time to normalization of lactate to hospital mortality, correlation of time to normalization of base deficit to duration of hospital stay, and correlation of the initial normalization of lactates to the hospital stay, and the initial serum lactate concentration and base deficit to the stay and the mortality. So methodology, a prospective observational study done in a critically ill adult patients admitted to ICU in a tertiary care hospital at a period of October to July 2023 to 24. So the inclusion criteria, adult patients admitted to general ICU or casualty ICU with shock, hypovolemic, cardiogenic, distributive or obstructive, or who had a diagnosis of shock within 6 hours of admission were enrolled. So shock was defined, the use of vasopressors for more than 1 hour. So exclusion criteria were the patients admitted to ICU with head injury and primary respiratory disorders, COVID-19 infections, and the discharge against medical advice were excluded. So sampling procedures, the observer 1 enrolled the patients after ensuring he or she meet the inclusion criteria and had none of the exclusion criteria. The obtained informed consent from the relatives being taken and recorded all the ABGs obtained and noted their trends, and followed up the patients to record their progress until the discharge from ICU and hospital. So observer 2, the intensivist in the ICU will alert the observer 1 whenever a patient with shock of any etiology was admitted to the ICU. So sampling size was calculated from my pilot study and from the previous studies. Total 100 were recruited, out of which 54 died and 46 survived. The mean age, gender, the type of admissions were comparable between the patients who survived and who did not. The duration of ICU stay was comparable between the two groups. The duration of mechanical ventilation was significantly high in the mortality group. So these graph, figure 1 depicts the x-axis, the time of duration of normalization of base deficit, less than 6 hours, 6 to 12 hours, 12 to 24 hours. And y-axis depicts the mortality rate. So as we can see that the normalization after 48 hours, like lot of mortalities, and as well as in figure 2, the normalization of lactates after lactates going about 48 hours, the mortalities have been high. So this graph, the x-axis, the time to shows the time to normalization of base deficit, and y-axis the duration of hospital stay. So there you can see a lot of clashes all over it. So definitely there is a confounding factor, so that the hospital stay is not significantly correlated. And same with the normalization of serum lactate. So the early normalization of base deficit and lactate was strongly linked to survival, to higher survivals in critically ill patients. The hospital stay, while the normalization of these markers predicted the survival, it had no significant impact on hospital stay duration, suggesting other factors influence recovery time. So the patients requiring mechanical ventilation had significantly higher mortality, reflecting the severity of the condition. So the ICU stay and hospital stay, survivors had a longer hospital stay, likely to the prolonged recovery needs, despite similar ICU durations for both survivors and non-survivors. So limitations, this was a single center study with a sample size of just 100. So although we wanted to enroll all the consecutive patients, there were a lot of missed patients and difficulty in enrollment. So conclusion, survival is higher in patients who has a early normalization of a base deficit and serum lactate. So the duration of hospital stay has no correlation with time to normalization of base deficit and serum lactate. Definitely there are a confounding factor. So the mortality does not correlate with the initial and base deficit and lactate concentration. This is my reference.
Dr. Gokul
yes, sir.
Made a good presentation. However,
thank you, sir.
I have some questions about
yes, sir.
What parameter you used to calculate the sample size?
Yes, sir. Like with the pilot study, we had a 30% survival rate, sir. So with the previous studies, we came to a conclusion of 100 patients.
Now you said your pilot study was the basis for calculation of sample size.
Yes, sir.
Now you are telling your previous studies were the basis.
So we took both the took both.
And
the
you
things.
did not tell me what are the parameter you used to calculate sample size.
So with the previous studies only we calculated, sir.
All right. When you speak about the survivors and the base deficit and metabolic acidosis, it is simple logic that severity of shock.
Yes, sir.
And the etiology of shock both play a significant role in
yes, sir.
mortality and survival and duration of hospital stay as well.
Yes, sir.
Did you factor those things in your study to find out the outcome? Because you have never told us what are the reasons for admission to ICU.
Yes, sir. We just we took both the patient with the. We took the patients with the base deficit most greater than -5, sir. So, but we didn't specify the etiological thing.
Looking at your parameters that you have taken to compare, the deaths, probably early deaths in the ICU should have been considered rather than the long I mean, as you go further,
Yes, sir.
there might be other complications that are setting in and
Yes, sir.
contributing to the death. So they cannot be factored into all these mortalities and relation with your parameter that you are measuring, right?
Yes, sir.
So what made you think that you don't have to consider that point?
So the duration initial, that's why we thought initial 48 hours, if the normalization would make an impact. So definitely the confounding factors are there, sir.
No, what I'm asking is, suppose somebody dies on the 20th day.
Yes, sir.
He is also included in the deaths, no?
Yes, sir.
But that might be to a totally different reason. He might
Yes,
have
sir.
had vented
Hospital
pneumonia,
acquired,
hospital
yes, sir, yes, sir.
infections. So that doesn't actually relate to the primary event
Yes,
that has
sir.
caused his outcome.
Yes, sir.
So we cannot factor them in. So there
Yes,
is
sir.
going to be a bias based on that, one thing. Second thing is, what was the intention of looking at lactate? Suppose you are looking at one parameter, you should have stuck to one parameter rather than getting to
Yes, sir, that's
another parameter.
Yes, sir. That's a secondary objective. Primary was a base deficit.
No, I think you should have focused on that
Yes,
and got it. As Dr. Sripad was telling, probably looking at the etiology of the shock. That again contributes a lot. No? A patient who has got a distributory shock or a cardiogenic shock, their outcome is going to be totally different.
Yes, sir.
They both will have metabolic acidosis and they both will have anion gap.
Yes, sir.
They are all going to have these problems. But then etiology is definitely going to change the outcome. Correct?
Yes, sir.
So those have to be factored in. The etiology has to be factored in.
Okay,
That's
sir.
not done.
Pass.
Thank you for that engaging session. I now invite our fourth presenter, Dr. Matthew, to take the stage.
A very good afternoon to one and all. I'll be presenting on the topic comparative effects of low dose with conventional dose fentanyl infusion in preventing sevoflurane-induced emergence agitation in pediatric patients, an observational study. Emergence agitation in pediatric patients can be upsetting for the patient, parents, and carers, potentially leading to the unintended harm. Different modes and doses of fentanyl delivery have been studied in the past to counteract the emergence agitation caused, but studies on low-dose fentanyl infusion were limited. This study seeks to compare the efficacy of low-dose with conventional dose fentanyl infusion in mitigating the emergence agitation without postponing extubation. Our study design was, it was a prospective observational single-center study. We included patients scheduled for elective surgeries under general sevoflurane anesthesia for a minimum of 1 hour at tertiary care hospital. Our inclusion criteria was ASA class 1 or 2 and aged between 3 to 14 years. Our exclusion criteria included patients who had neurological disorders and neurodevelopmental delays, history of sleep apnea, acute upper respiratory infection, history of allergies to the study medicines. All patients underwent preoperative assessment and informed written consent was obtained from the parents of all participants in the study. Patients were fasted according to the standard fasting guidelines. The child was assessed for any anxiety half an hour prior to surgery. If the mViPA score exceeded 30, IV midazolam 0.05 mg per kg was administered. On arrival to the operating room, ASA standard monitors were attached. Anesthesia was induced with IV propofol 2 mg per kg and deepened with sevoflurane adjusted to an end-tidal concentration of 2 to 3%, paralyzed with IV atracurium 0.5 mg per kg and intubated with an appropriate size tube. Regional anesthesia was administered wherever applicable as per the decision of the consultant anesthesiologist. During the surgery, anesthesia was maintained with sevoflurane 2 to 2.5% in approximately 50% oxygen with a total inflow of 2 liters per minute to obtain cumulative minimum alveolar concentration of 1 to 1.5 on controlled ventilation. The fentanyl infusion was started after a bolus of IV fentanyl 2 mic per kg, and this was at the discretion of the consultant anesthesiologist. They decided whether to start an infusion of 0.5 mic per kg per hour, which is the group F0.5, and 1 mic or 1 mic per kg per hour, which was the group F1. Fentanyl infusion was stopped 15 minutes prior to the end of surgery. Prophylactic IV ondansetron 0.1 mg per kg and IV paracetamol 15 mg per kg was administered over 15 minutes towards the end of the surgery. The inhalational agent sevoflurane was tapered and cut once the procedure was over, with an increase in inspired oxygen to 100%. Child was reversed with IV neostigmine and glycopyrrolate. Gentle oral suctioning was done. All subjects were extubated when they started breathing spontaneously, taking adequate tidal volumes with a regular respiratory pattern. After extubation, the patients were transferred to the post-operative anesthesia carry-on. Our outcome variables was time 0. This was the time of discontinuation of sevoflurane. Time to extubation. This was the time from the stoppage of inhalational agent to the removal of the ET tube. Emergence time was the time interval between immediately after extubation and the time of resumption of mental orientation in PACU. This was taken once the subject was able to recognize the parent. The child was observed for every 5 minutes for the first half an hour in PACU. The level of emergence agitation was assessed by the PEAT score. A score of more than equal to 10 was regarded as agitation and IV fentanyl 1 mic per kg. The post-operative pain was assessed using Wong-Baker-Faces pain scale. If the score was more than 4, IV fentanyl bolus of 1 mic per kg was given. All children were observed for any post-operative nausea and vomiting and any other side effects in the PACU. They were discharged from the PACU if the modified Aldred score was more than equal to 9. Time to discharge from PACU was noted. Coming to my discussion, the first figure shows the presence of emergence agitation in both the F1 and the F.5 group. We can see that 6 of them had emergence agitation in F1 and 3 had in F.5, which are comparable statistically. The time for extubation and emergence time was again comparable in both the groups. The second table shows association between regional block and emergence agitation. Here there was a significant decrease in emergence agitation in the patients who received regional block. There was no impact of preoperative anxiety on postoperative emergence agitation as per our study, which we observed. And the rescue analgesics which were used in PACU in both the groups were comparable. The duration of stay in PACU showed no statistical difference between both the groups. None of the subjects experienced postoperative nausea and vomiting. Coming to my discussion, the study found that intraoperative fentanyl infusion at either doses following a bolus dose of 2 mic per kg fentanyl reduced the incidence of emergence agitation after sevoflurane anesthesia in children in a comparative manner. Previous studies had found that children who had sevoflurane anesthesia responded favorably to dose-related effects on smooth intubation and a considerable reduction in emergence when given 2 mic per kg fentanyl initial dose followed by an infusion of 1 mic per kg per hour. The study found no undue prolongation in extubation or time to discharge from PACU, no delay in recovery or discharge from PACU by the administration of fentanyl with either of the doses. There was significant reduction in the incidence of emergence agitation in children who received regional anesthesia concurrently with general anesthesia. Coming to my limitations, the study was an observational study, not a prospective, randomized, controlled, double-blinded study, and the use of premedications of IV midazolam nitrous oxide could possibly alter the emergence agitation. Further studies may be undertaken as randomized controlled clinical trials in larger number of children, focusing on one particular type of surgery, assessing the emergence agitation with different doses of fentanyl. These are my references.
No, towards the end of your study, you realized the limitations.
Yes, sir.
Why that didn't happen in the first place
Sir,
when you designed your study?
Yeah, so our study was actually based on a study which is published in BJA. So they also compared the 1 mic per kg and the 0.5 mic per kg infusion doses, but their bolus doses were different. So we also expected that with the bolus doses were different in their study for each of the infusions. So we expected that the bolus wouldn't make much of a difference, and our study was very much, even they had studied all of the cases from different surgeries. Like what I mentioned here was, we should probably, when we go ahead, we should stick to one particular type of surgery. But their study was also conducted in patients who are operated in different surgeries, ENT, they had ortho surgeries and general surgeries. So that is why we didn't alter much from what was done in their surgery. In the study we based our study on.
Yeah, that is two other things that you are talking about. The technique of anesthesia, whether you're adding regional anesthesia or nitrous oxide to your anesthetic, definitely will alter the patient's agitation levels and things like that. So you're measuring a measurable without a comparativity among the groups. So that defeats the whole purpose. No?
No, so again, the regional anesthesia part was not, that was not a parameter in that study. This was something which we observed in our...
No, that is what I'm saying. The scientific advancement means we realize a deficiency in a study, and then we need to get to a point where we don't do the same mistake and try to observe.
Yes.
Correct. So
Yes.
if that study didn't have it, then we realize that there is a problem.
Yeah.
So we should have corrected that part and then gone ahead.
Yeah.
Correct.
Yes, sir.
So that is the basis for scientific advancement.
Okay, Matthew, good presentation.
Thank you, sir.
Fluency was there. I just want to ask, this slide which you said the study was observational study, not a prospective. That means you have done a retrospective analysis of the files?
No. I meant it should have been a double-blinded, prospective double-blinded
Randomized
study. Yeah,
control
randomized
study.
control prospective.
So you are saying that.
Yeah.
So this is also a prospective study.
Prospective
correct?
study, yes.
Okay. And then, see, there are a couple of things which are, as Satyajit also pointed out, fentanyl infusion 0.51 is also depending on, probably your surgical selection is also not same, isn't it?
No, sir, it's not same.
You said orthopedics were there,
Yes,
some
sir.
other surgeries were there. That also might have determined. So many things like post-operative, how child is agitated or not, all those things depending on how well the pain is controlled.
Yes.
Regional as well as this.
Yes.
Do you agree with that?
Yes, sir.
Okay. So probably when you go into like a observational study, you may have to further narrow it down and see that similar things are being done, and then you want to check whether they are okay.
Yes, sir.
Then only you can come to a conclusion whether one is better than the other or something like that.
Oh.
I know prospectives, the observational studies, you can't control many of the things,
Yes.
but then you have to limit your selection of cases depending on some of them.
Okay.
I think time is up. Okay. Thank you.
Thank you all for the informative session. I now invite our fifth presenter, Dr. Sushmita, to take the stage.
Good afternoon. I'll be talking about the comparative study between vapor coolant ethyl chloride spray and 10% lignocaine spray in minimizing pain during pediatric peripheral intravenous cannulation. This is a randomized control trial in a tertiary care center. Peripheral IV cannulation before anesthesia is necessary, and especially in children, it causes pain, distress, and anxiety. And factors such as age and anxiety can influence the pain perception, and therefore it makes it important to reduce this discomfort. It not only affects the children as well as their caregivers. Pain and anxiety are closely related, so therefore pre-procedural anxiety, to reduce it, there must be measures that are taken. Various methods have been explored, and emphasis of this study lies on providing a painless and non-invasive topical anesthesia for cannulation purposes. So therefore, I have taken the topic of comparing the effectiveness of 10% lignocaine and vapor coolant ethyl chloride spray. My primary objective being it to determine the efficacy, and secondary objective being the assessment of time taken for venous cannulation, ease of cannulation, and occurrence of any adverse effects. I have included patients between the age groups of 8 to 17 years of ASA 1 and 2 of either gender posted for elective surgical procedures requiring anesthesia with no prior IV cannula. And exclusion criteria, I've excluded patients who have undergone emergency surgeries, syndromic children, decreased level of consciousness, intellectual disabilities, adverse allergic reaction to lidocaine or prilocaine, pre-existing sensory or motor deficits in the limb to be cannulated, or even if the limb has burns, local infection, skin lesions, or broken skin. The sample design was a single center prospective, double-blinded, randomized study, and the sampling technique was done by computer-generated randomization. My variables that I had compared was 10% lignocaine spray and ethyl chloride spray. My sample size was calculated to be around 60 based on a previous study with a confidence interval of 95% and a power of 80%. And the study group was between 8 to 17 years for a duration of 1 year. I have two groups here divided into group L and group E. Group L had an application of 10% lignocaine spray 3 times at the cannulation site at a distance of 5 centimeters, followed by a transparent occlusive dressing for a duration of 10 minutes prior to the cannulation. And group E had 3 sprays of ethyl chloride for a period of 4 to 6 seconds at a distance of 5 centimeters. This would result in immediate and effective cryoanalgesic state, which lasted for a period of about 2 minutes. And the tools that I've used in the study is the Fitzpatrick scale for determining the skin shade, visual analog scale for pain, and Likhart's 4-point scale for the ease of cannulation. The patient details of age, gender, height, and weight were noted, the skin shade was noted, and the target vein visibility and palpability were also noted. Procedural-wise, the hemodynamics, that is the heart rate, systolic blood pressure, diastolic blood pressure, and saturation were noted at baseline and 5 minutes after the procedure. The VAS score was also noted, time taken for cannulation, ease of cannulation, and adverse effects. So the methodology included a preoperative evaluation performed a day prior to the surgery, and if the inclusion criteria was satisfied, the pediatric patient was taken in for the study. A written informed consent was taken from the parent and an assent from the participant as well. After recruitment, the child was pre-medicated with alprazolam based on the body weight followed as per standard practice, and subjects were wheeled into the pre-medication area 2 hours prior to the planned procedure. The subjects were then briefly explained about the VAS score, that is 0 to 100, and venipuncture was performed by aseptic precautions using by decontaminating it with 70% isopropyl alcohol, and then followed by cannulation by the consultant anesthesiologist. Once the correct placement was confirmed, it was connected by a T extension and a secure sterile dressing was placed. After the cannulation process, the child was asked to rate the pain based on the VAS scale. Here, the subjects as well as the consultant anesthetist were blinded to the study by saying that a foil was covered on the sprays and stating that either of the sprays would have been used. As for the results, the visual analog scales, as we can see, in group E is only 2 to 5 with a lesser score, and group L with a higher score of 5 to 9, making it statistically significant. And the time required for cannulation was less in group E compared to group L, again making it statistically significant. And the ease of cannulation in group E, 30 patients, that is half of the patients who were recruited had no problem in cannulation, whereas group L, there were some difficulties, 7 in minor and moderate problem as 2. Parameters as compared, we have the heart rate. It was not significantly increased in group E, but in group L, it showed a significant increase. The same goes for systolic pressure and diastolic blood pressure as well. There was no change in oxygen saturation, or there were no adverse effects. So pre-procedural anxiety, it is important to eliminate it in pediatric age groups, so therefore we had given alprazolam. And vapor coolant spray acts quickly, requires no pre-treatment, and makes it practical and easy to use, whereas lignocaine gives a longer lasting action. And there are many supporting studies that ethyl chloride reduces pain and complications, especially for IV cannulation and radial coronary angiography procedures and spinal injections as well. And we were concerned about the sterility of ethyl chloride spray, but according to research, it proves that it is safe to use. My limitations were that it did not compare to our standard IV cannulation care, that is the use of EMLA. It consisted of only older patients, and the cannula size was limited only to 20 and 22. We did not evaluate the cutaneous vasodilation that could occur with ethyl chloride spray as per previous research.
The basic premise of this study is that a lignocaine spray acts transcutaneously.
Yes, sir.
Point number 1. Second is vapor coolant spray. Though it gives analgesia, how long it lasts till the cannulation is successful after you clean the skin and let the spirit dry about 30 to 60 seconds and then attempt the cannulation. And whether the cannulation was succeeded in a single attempt, if not what. These things were not specified there in the methodology.
Sir, in this ease of cannulation was the single attempt or multiple adjustments being required for the cannulation process. So within ethyl chloride spray basically acts within less than, the action lasts for about 2 minutes but acts immediately. So once we sterilize the area that has to be cannulated, we would spray the ethyl chloride spray.
Yeah, that's right, but the thing is now lignocaine spray,
Yes.
does it act transcutaneously?
There is a content of polyethylene glycol which is used in the medication. So that acts as a humectant and moisturizer. So it basically makes the lipid layer of the stratum corneum to be more like emulsifiable. So it makes the active substance penetrate much better. The same content
that
is also
correct.
present
that is right, but with how long it takes to work, it may not work within 10 minutes because it has not been so effectively used in other places.
Yes, sir. But we have taken a minimum.
So therefore, if you had a control, you could have said, okay, the lignocaine 10% spray has an effect.
Yes,
Without
sir.
a control, difficult to say.
Yes, sir. In my main thesis, I did mention that that is also one of the limitations.
And the age group 8 years to 17 years is a very wide, and there are a lot of issues including ethics, permission, and the consent. 8-year-old whether can understand a visual analog scale scoring.
In the 60 patients that I had used, I did not find any. The basis of starting it from 8 years was that they have a verbal maturity of understanding and expressing pain in terms of the intensity, the location, and the duration better. So from in the pediatric age group, I had to take 8 years.
Yeah, just adding only one question to what he has already asked. The onset and duration of action of these two drugs are totally different. And I think your IV cannulation, what is the usual time you started and how long it ended? I think it's something like 5 minutes or something, which you have mentioned. IV cannulation time somewhere? No, down?
Ease of time required for cannulation, sir.
Yeah, how much it is? What was the time required? Because see, what happens is your coolant spray, it's only 2 minutes it works, and many of the time your IV starting is much after that. And lignocaine probably by that time would not have acted. And then so comparing these two are little not of similar action and similar onset of time and duration of action. I would think that is one of the. And do you have any explanation, very high success rate of the ether coolant spray, IV cannulation, almost 100%, right? Compared to the other one. Why the other one? Because these are not very small children. They are reasonably okay to start the cannulation, all that. Why other success rate is not that high? Any specific reason you can think of, or you are giving any explanation for that?
I would believe that it is because of the coolant effect that children experience once the spray is put on, sir. Whereas for lignocaine spray, we had to put the spray and cover it over with an occlusive dressing for a period of about 10 minutes prior to cannulation. So they psychologically also the factor of pain is there. So they might have thought that it could be a procedure, that's why they have banded it. Whereas with the vapor coolant ethyl chloride spray, it is very immediate and gives a cool effect, which numbs the pain. So maybe that's the reason they had lower pain score. The coolant effect basically helps in reducing the pain.
Okay, thank you. Time is.
Thank you for the informative session. I now invite our sixth presenter, Dr. Apurva, to take the stage.
Good evening, esteemed judges, panel members, and all the audience members. I am Dr. Apurva, and I am here to present my study, a prospective study to compare intubation prediction score versus Wilson score for prediction of difficult endotracheal intubation. As anesthesiologists, securing an airway is the prime goal for any case of general anesthesia, and the gold standard for that till this date remains tracheal intubation. Difficult airway is a clinical situation where a conventionally trained anesthesiologist experiences difficulty with mask ventilation or endotracheal intubation or both. Airway assessment, hence, is a routine and important step during pre-anesthetic checkup at bedside. The possibility of a failed endotracheal intubation, hence, is a complication which, if foreseen, will be easier to mitigate. As per a research conducted by Kaplan et al. In 1990, 17% of intraoperative respiratory complications are owing to unanticipated difficult airway, and 85% of these complications, 85% of these patients either die or suffer from hypoxic brain injury or other morbidities. Several independent bedside tests exist for predicting the same, namely Mallampati score, mouth opening, sternomental distance, upper lip bite test, thyromental distance, etc. But it has been found out as per literature that none of these independent bedside tests were suited for detection of unanticipated difficult airway with consistency and accuracy. A combination of these tests, however, improves the accuracy by leaps and bounds. Several scoring systems have been described but haven't gained popularity as they are perceived to be cumbersome to perform with inter-observer bias. Hence, our endeavor in this research is for searching a simple and practical score to predict difficult airway better, and we have selected two objective scores for the same, namely Wilson score with the following parameters of weight, head and neck movement, temporomandibular joint movement, receding mandible and buck teeth, and intubation prediction score with three parameters, namely Mallampati grading, atlanto-occipital joint extension, and mandibular space. I will be expanding on the scores in methodology. Our primary aim is to compare and determine the diagnostic accuracy of Wilson score and intubation prediction score for predicting difficult airway in patients undergoing surgery under general anesthesia. Our objectives are to compare sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of both these scores. Moving on to the methodology, patients were selected as per the inclusion criteria and pre-operative history and examination was carried out. Informed consent was taken after orientation to study design. Detailed airway assessment was carried out as per both the scores in each and every patient. In Wilson score, we have the 5 parameters as enumerated before: weight, head and neck movement, jaw movement, receding mandible, and buck teeth. Each of these parameters were graded between 0 to 2, and a total score was calculated. The total score, if less than or equal to 2, was graded as easy intubation. A score of 3 to 7 was graded as moderately difficult intubation, and a score of more than or equal to 8 was graded as difficult intubation. For intubation prediction score, we had 3 parameters, namely Mallampati test, atlanto-occipital joint extension, and mandibular space. Atlanto-occipital joint extension was measured using a goniometer, and mandibular space had 2 parameters, namely thyromental distance and mandibular length. It was graded between 1 to 4, and a total score was again calculated. A grade 1 was easy intubation, that is 3 to 4 points. A score of 5 to 8 was predicted as moderately difficult intubation, and a score of 9 to 12 points was graded as difficult intubation. After airway assessment was given, if either of the scores predicted difficult intubation, a difficult airway cart was kept ready intraoperatively. General anesthesia was induced as per standard protocol with endotracheal intubation for all the patients. Cormack-Lehan grading was noted during laryngoscopy, and post-induction, intubation difficulty scale questionnaire was asked to be filled by the intubating anesthesiologist. The intubation difficulty scale has 7 parameters. Each of them has a different scoring system, and a total score of more than 5 is considered as a difficult airway. For all the 50 patients selected for the study, a statistical analysis was done after that. Data was collected and statistical analysis was done after that using an SPSS version 25 software. A p-value of less than 0.05 was considered as significant, and frequency and percentage difference was tested by the chi-square test. Out of the total 50 patients, 12 patients had difficult intubation. Actual difficult airway was assessed intraoperatively, and percentage of predicted and actual difficult airway was calculated. So out of the 50 patients, 12 patients had actual difficult airway, out of which Wilson score predicted difficult airway in only 3 patients, that is true positive of 3 and false negative of 9 patients. In intubation prediction score, out of the 12 patients, only 1 patient was a false negative and 11 patients were true positive, that is actually predicted as difficult airway. This was statistically significant by a p-value of Wilson score being less than 0.04 and an intubation prediction score p-value less than 0.0001. Moving on to the qualitative parameters, Sensitivity of Wilson score was a meager 25%, standing next to 91.67% sensitivity of IPS, thus IPS being better at predicting the true positives. The specificity was comparable in both. Still, intubation prediction score had a better specificity at 97.37%. Positive predictive value was again better for IPS at 79.47%, and a negative predictive value was comparable, but IPS had a near perfect score of 99.06%. The results of this study are similar to a previous study in Eastern Indian population in which IPS had a higher sensitivity, specificity, and positive predictive value compared to Wilson score. Wilson score is considered a simple bedside scoring system, but has a lower sensitivity and positive predictive value. IPS, on the other hand, has 3 clinical and objective parameters and higher predictability, which will result in less inter-observer variability and will be easier to implement. To conclude, IPS has a better sensitivity, specificity, positive predictive value as compared to Wilson score, and it can be preferred as a simple and accurate bedside test to predict a difficult airway. Here are my references. Thank you.
That was a tidy presentation, Dr. Apurva.
Thank you, sir.
According to you, what is the prevalence of difficult intubation in general population?
Sir, as per a previous study, it was 12% was the predicted difficult intubation.
When you want to compare the population who actually have difficult airway, difficult intubation or difficult laryngoscopy, what should be the sample size? You have taken only 50 patients.
Yes, sir. I have taken an alpha error of 0.02 and
now the parameter what you took to compare the outcomes is more important than the statistical limits what you have taken.
Yes, sir. Sir, as per a previous study, I took the alpha error as less.
No, I'm not interested in alpha error and beta error. I'm interested in the parameter you chose to select the sample size.
Sir, I took a reference from a previous study in which the sample size was 48 patients, sir.
All right, and second thing is in IPS, the details of the scoring had to be elaborated. It's only arbitrarily numbers are put. The scoring system is not specified there.
So may I expand?
Yes, please. Yeah.
So in weight of less than 90 kg, it is given as 0. 90 to 110 kg is given as 1 and 2.
No, there is no weight category in this IPS.
Oh, sorry, sir. Yes, sir. In Malampati grading, it is according to the MPG grading of 1, 2, 3, 4 standard.
Yeah,
in Atlanta occipital joint extension, less than 35, more than 35 degrees is given as a 1. 22 to 35 is given as 2. For 3, it is less than
the
20.
other parameter you had to compare was the demographic data was more important in this population. It was not compared in your results.
Okay, sir.
Yeah, I think for a airway study, it has to be a little larger number maybe.
Yes, sir.
Predicting, because as it is, the difficult airway is not that common.
Yes, sir.
Have you specified the type of blade and how it was used or anything like that? Because you are intubation, right?
Yes, sir.
Whether any aid has been used or something like that?
Yes, sir. In out of the 12 patients, 5 patients were
12
intubated.
who had difficulty you are talking about? Or
so difficulty was calculated as per the intubation difficulty scale only.
Okay.
And aids were used in 5 out of the 12 patients. In like intubating stillet was used in 5 patients, and 2 patients had to undergo fiber optic intubation, sir.
the option was given to the operator, or option was decided with certain parameter or certain difficulty?
Sir, option was decided as per the difficult airway algorithm, sir.
Okay.
Thank you all for your valuable perspectives.
Thank you, sir. Thank you.
I now invite the last presenter, Dr. Yashwant Kona, to take the stage.
Good afternoon, everyone. My paper is Evaluation of Efficiency of a Novel Anesthesia Safety Checklist in Simulated Emergency Caesarean Sections. It's a CTRI approved trial. Introduction. So medical checklists, as we know, we do use the WHO surgical safety checklists. They are crucial tools in used in healthcare and other branches also, which help in ensuring that critical steps are not missed, and they improve patient care, enhance safety and quality of the procedures, and they also standardize it. These are especially important in contexts such as surgeries, patient care, and emergency places. So emergency cesarean section, which is considered a high-stake procedure, which can happen at any time of the day, requires prompt and coordinated actions by a multidisciplinary team, including anesthetists, surgeons, and the nursing staff. So in this aspect, I consider doing a safety checklist to see if it can be used as a tool to benefit the anesthesiologists. So the aims and objectives of this study. The study evaluated the effectiveness of a novel anesthesia checklist for pre-anesthetic setup, that is OT preparation, in a simulated emergency cesarean scenario. Our checklist was made using the Delphi method, where 7 senior consultant anesthetists were consulted, a panel was formed, and a checklist was made. And only after the approval by the anesthetist, along with the quality implement officer of the study site, we were able to use this checklist. The specific objectives that we wanted to see are assessing the number of steps that are missed during the pre-anesthesia setup in these procedures, and evaluating the checklist utility in the preparedness of the operation theater and the anesthesiologist's comfort with the checklist. So this is IEC approved and CTRI approved trial. It's a single center prospective study, and the methodology was parallel cross-sectional analytical study, and the variables being those that use the checklist and those that have not, which is the routine way of doing things. The study is yet to be published. Postgraduates, so how it was done was that postgraduates preparing an operation theater were told to prepare the theater both with and without the checklist. The postgraduates were divided into 12 second years, 18 first years, and 20 first years, 12 second years, and 18 first year postgraduates. The same postgraduates were made to prepare the operation theater with and without the checklist on 2 different days. So the observer in the study was responsible for selecting the number of postgraduates and observed the number of steps that were missed during the preparation of the operation theater. So this is my checklist with the statistical results found. I'm happy to say that all emergency drugs were present with and without the checklist in our operation theater. We do see statistical significance in checking of a functional operation table, presence of tranexamic acid, presence of ondansetron in the operation theater, checking of blood forms that were available in the theater or not, and presence of oropharyngeal airways along with succinyl choline. So what this means is that people who have used the checklist found to have a higher number of equipment and drugs that were kept ready in the operation theater compared to the others who have not used the checklist. So we have divided our checklist into mandatory and desirable, as all equipment and drugs do not have equal importance. In our study site, the availability of body warmer, fluid warmer, colloids, noradrenaline ampules, syringe infusion pumps, and carbetocin inside the operation theater were considered desirable. All general anesthetic drugs and emergency drugs and drugs specific for cesarean section were considered mandatory present in the operation theater. So the results that we did find from the study were that 12 with and without checklist. So with checklist, the number of mandatory steps were that were missed were only 12 compared to 87 without the checklist. And also the desirable number of steps that were missed were 24 with the checklist and 108 without the checklist. So this shows a statistical significance with a p-value of 0.036. All participants that performed the study found the checklist to be useful and comfortable. The other point that we could find from our checklist was that the reliability of the checklist. So that was calculated using the KR20 formula, Kuder-Richardson formula, which gave us a value of 0.889. This suggests that the checklist is very reliable and the options present are consistent with each other, and it has good reliability in overall use. So conclusion, a checklist in emergency cesarean section can be used as a tool to guide postgraduates to keep necessary equipment and drugs in the operation theatre, thereby reducing errors and improving patient care. The limitations of our study includes that it's a single-center study. We have also not used it in actual cesarean section, so a real-time analysis of the checklist has not been done, which we plan to do further as a randomized control trial. These are my references.
Dr. Yashwant, that is an innovative intervention.
Thank you, sir.
May help in improving the safety in the operation theatre.
Yes.
Did you take the consent of the participants?
Yes, so all postgraduate consents were taken.
Not mentioned. And what was the location of the study?
The location was in the single tertiary hospitals. That was conducted in the main OTs as well as the OBG OTs that were present in the hospital.
And how did you arrive at sample size, whether it is only convenience or whether there was any...
No, sir. So study was conducted in 2015 by Shaw and all, which was published in Anesthesia and Analgesia. They consider an error of 11.5% to be significant. They have made an anesthetic pre-induction checklist to be used amongst all the consultants and the residents of UK in that single study center and published the findings. The checklist again was similar to what we have made, but was purely for general anesthesia cases and was for seeing information exchange and handovers in between various consultants.
When you study the same group of people,
Yes.
there is something called learning during doing. So what happens when you repeat the same thing next day? The performance will automatically improve. Did it affect your study?
So we did not do it in the very next day itself. So there was a time difference of a few days between the same postgraduate. And initially they did not use the checklist to prepare the OT. That was the first way of doing the study. Only the same postgraduate, after a few days later, was responsible for using the checklist and conducting the study again.
Yeah, just highlighting the last question which he has already asked. Was it randomized, whether they are doing with the checklist, without checklist?
The same postgraduates were selected, sir, and we used a simple random technique, computer-generated technique to
So some
allocate.
of them have started with the checklist first and then without the checklist.
No, they're all without the checklist first and then with the checklist. Once only we knew which postgraduates were selected via simple random sampling, did we then proceed with starting the study.
So everybody started without the checklist and then
Yes.
they started with
Yes.
the checklist. Okay. And you said simulated emergency cesarean or something like
Correct.
that. What exactly that means?
Yes, so we have told the postgraduate that the pre-anesthetic checkup of a patient for type 1 emergency cesarean section has already been done, and a 5-minute time interval was given for them to prepare the operation theatre.
They have been given any details about the simulated patient or anything?
They've only been told it's a class 1 emergency cesarean, sir. Exact values of HB and all were not told to the postgraduate.
Yeah.
With that, we come to the end of today's paper presentation session. I would like to extend my heartfelt gratitude to our esteemed judges for their insightful feedback and a sincere thanks to all the participants for presenting your work. I now invite our judges to kindly move on to the dais, and I would also like to request Dr. Ramkumar to kindly come forward to felicitate our judges. Thank you, Dr. Manjunath. Thank you, Dr. Satyajit. Thank you, Dr. Sripada Mahindale. I would like to request all the presenters to kindly come onto the dais. Thank you all. I request all the delegates to kindly scan the QR code which will be displayed on the screen and fill out the feedback form. Kindly note that certificates for the CME will be given only after the CME forms, the feedback forms are filled. We will now have a short tea break, followed by the quiz finals, valedictory function, and prize distribution.
Okay, so we'll welcome you all to the quiz finale. A big round of applause for all the teams who have qualified. We had 32 teams, that's 64 participants, and they have qualified amongst all of them. So that's a big lead. So 1 out of 6, more than that actually. That's great. So we'll start the quiz. Just few ground rules before we begin. So there's it's an infinite bounds quiz, which means that we'll begin clockwise. We'll start with the first team, and the question will be direct. It will be 10 points for the first round and the second round as well. Okay, and what happens is if you answer direct, you get 10 points. If you can't answer, it passes to the next person, next team, sorry, and they also get 10 points. Okay, if you answer, then the next question goes to the other team. So whoever answers, the next question goes to the other team. That's the concept of infinite bounds. Okay? There's no partial points. Will decide if, depending on the answers, if it requires, it can be allotted a partial point. We'll see. Okay? Otherwise, no bonus pass points are not there. Just direct points, 10 points for all. Round 3 will be a buzzer round, which I'll explain when we get to that round. Scoring on each round will be discussed during each round. So, Quizmaster's decision is final. No prompting, no answering out of turn, no answers through any electronic devices from your friends in the audience, please. Yes, fun answers are appreciated, but you will not get any points for that. Okay, let's meet our teams then. First, we have the first team, Legend It For It Dairy. We have, please introduce yourselves and your college.
I'm Dr. Sushmita from KMC Manipal.
I'm Dr. Nikhil from KMC Manipal.
Big round of applause for them. Next team.
I'm Dr. Indumati from Anapoya Medical College.
I'm Dr. Arpita from Anapoya Medical College.
That's great. They are the narcotic nerds. Okay, next team.
I am Dr. Debauti from KMC Manipal.
I'm Dr. Sheetal from KMC Manipal.
Yeah, they are needle ninjas.
I'm Dr. Shravan from PSG.
All right.
I'm Dr. Kavya from PSG.
Yes, convenient naming, PSG. Okay, next.
I'm Dr. Junejo from Goa Medical College.
And Dr.
I'm Dr. Aki from Goa Medical College.
Okay. Team Keto Fall. So welcome all. All the best to all the teams. So first set is the general round. Okay? We'll start clockwise. We'll start with Legend. It's a big mouthful of a name. Team 1 first, okay? Okay, question 1. Starting. X is a class of anti-diabetic drug which mimics the action of the endogenous hormones. It is said to have cardio and renoprotective actions. Currently, it is also marketed as a weight loss drug. Please, audience, I request not to prompt anything. Huh? Anecdotal reports have raised concerns of X leading to delayed gastric emptying, and patients who use X have a higher risk of aspiration. While advisories have suggested to withhold its use preoperatively, its long duration of action can lead to practical problems in withholding these drugs. What is X?
SGLT2 inhibitors.
Agreed? Want to improve your answer? Next, we'll go to the next team. Team Narcotic Nerds. Yeah, class.
Vildagliptins?
No. Next.
Metformin.
No. Team PSG?
So GLP-1 analogs.
Can you
GLP-1
repeat?
GLP-1 analogs.
Do you want to give some names? Okay, I'll give it to you. I'll give it to you. It's GLP-1 agonists, commonly known as Ozempic drugs that are going on. Okay? So 10 points to Team PSG. Well done. Round of applause, guys, please. Okay. Next, for Team Ketofol. X was initially introduced as a fluorinated hydrocarbon for use as an inhaled anesthetic agent. In the mid-1960s, concerns over the renal toxicity with the use of X began to emerge. Two significant case series described an unusual form of high-output acute renal failure. While the exact cause of renal tubular dysfunction was never established, X was withdrawn from market. However, X recently made a comeback in the last decade as a low-dose handheld inhaler for analgesia in acute trauma. Marketed as Penthrox, a 3 ml vial delivers X as an inhaled concentration of 0.2 to 0.4%. Can you identify X? Team Ketofol.
Methoxyfluorine.
Excellent. Answer is methoxyfluorine. 10 points to Team Ketofol. Okay, next goes to legend, wait for it, Derry. Okay. Multiple studies have helped shape this vital theory by Patrick David Wall and Ronald Melzack. First, the demonstration of presynaptic inhibition of unmyelinated small fibers. Second was amongst patients with herpes zoster, analysis revealed patients experienced excruciating pain in response to gentle stimulation of the affected area. In affected areas, it was hypothesized that large fibers normally inhibit small fibers. Third was that the cells of substantia gelatinosa play a role in its presynaptic activity. What theory is being talked here?
Gate control theory.
Very nice. This is the great control theory by Melzack and Wall for pain. Okay, 10 points to Team 1. Okay. Next, Team 2, narcotic nuds. The Elwell model was proposed in 2018 and is built from a pooled data from 1,033 patients aged half years to 88 years, weighing between 680 grams and 160 kg. It is universally applicable to patient population and a clinician encounters it in everyday practice. It includes adjustment for age, weight, height and sex, and for the use of opioids. It can be used for both anesthesia and sedation. It has the lowest prediction error in adults and low bias in children and obese patients when compared to its other models. The other models are very common models you might be knowing. So what is this model being used for? I just need, what are we being talked about here?
Remifentanil infusion.
No, I think we'll pass it to Needle Ninjas. Should attend your CMEs properly. I think everything was discussed in the CME today. Okay, we'll pass it to Team PSG. Needle Ninjas, okay? Passing to Team PSG. For pass, you don't get a lot of time, okay? Want to take a shot at it? No negative points.
Patient control anesthesia.
Sorry?
Patient control anesthesia.
No, I'm sorry, that's not the right answer. Team Ketofol, do you want to go for it?
Target control infusion.
Okay. Do you want to specify something about it? For what TCI are we using this? Can you? Which drug? We'll, sorry?
Propofol plus remifentanil.
It is basically propofol. Okay, we'll give it to you. It's propofol-based pharmacokinetic model for TIVA or TCA. Very good, very good. Round of applause for them. This was discussed today in the CME. Okay. Next, this team 1 will be answering this next, okay? What is X? A 60-year-old male patient with a large subdural hematoma requires emergency surgical drainage. He is known case of atrial fibrillation and is on oral warfarin for warfarin of 5 mg once daily. His prothrombin time is prolonged. His INR is 5.1. The warfarin is withheld and vitamin K is administered. The patient also received X after risk-benefit discussion of the bleeding versus thrombosis for immediate reversal of warfarin. The INR decreased to 1.3 after administration of X. X was initially developed as a source of factor 9 for patients with hemophilia B. Other clinical indications include bleeding in severe liver disease, reversal of other anticoagulants, and trauma-related bleeding. It can be given at room temperature without blood typing and is quicker in onset than other alternatives. What is X? Team legend, wait for it, Terry. It's a wordy question, but I think you can see a few clues there.
Ma'am, cryoprecipitate.
I'm sorry, that's not the right answer. Team narcotic nuts, they answered cryoprecipitate. That's not the answer. Take a quick guess, yeah?
FFPs?
No, sorry, that's not the right answer. Needle ninjas?
Prothrombin factors. Protein.
Prothrombin factor concentrate.
Okay, prothrombin concentrate. That's it. We'll give it the point. Prothrombin complex concentrates. Okay.
We will begin with the felicitation of the junior residents who have participated in the case discussion. Dr. Priyanka, Dr. Indumati, Dr. Monica, Dr. Yashas, Dr. Samriddhi, Dr. Manoj. Can you please come on the stage? Dr. Indumati. Dr. Monica. Dr. Yashas. And Dr. Manoj. Moving on to the postgraduates who have participated in the pro-con session, Dr. Soifa, Dr. Arpita, Dr. Surya. I request you to kindly come forward. Dr. Arpita. Next, we would like to felicitate the online judges for the paper and the poster presentation. I request Dr. Anita Shenoy to kindly accept. Dr. Arun Kumar HD, Dr. Sumesh T. Rao, Dr. Sumalata R. Shetty, Dr. Ram Kumar Venkateswaran. Dr. Malavika, Dr. Priyanka Kini, Dr. Ishwar MV, Dr. Vamshi, Dr. Ravi Tej, Dr. Megha T. Rao, and Dr. Lakshmi Shenoy. We thank you, judges. Next, coming to the winners of the paper presentation, the first prize goes to Dr. Yashwant Kona from KMC Manipal. The second place is backed by Dr. Neetu from KMC Manipal. The third place goes to Dr. Apurva from SBKS Medical College, Vadodara. Moving on to the poster presentation, the first prize is backed by Dr. Anisha Joy from CMC Vellore. The second place is backed by Dr. Sharon Ebenezer from CMC Vellore. I request Dr. Anita Shenoy, our organizing chairperson, to kindly come on the stage. We will be announcing the winners of the quiz. First place goes to Dr. Junejo and Raki Jose from Goa Medical College. They have bagged 120 points. I request Dr. Shreya and Dr. Savan to kindly join on the stage. The second place is backed by Dr. Sri Shravan and Kavya from PSG Institute of Medical Sciences. The third prize is backed by Dr. Sheetal N and Debahuti Chatterjee from KMC Manipal. Thank you, ma'am. Thank you, sir. Ladies and gentlemen, as we come to the close of this enriching CME for APGAP 2024, I would like to take a moment to express our gratitude to our distinguished speakers. Your contributions have truly enriched our understanding and practice. A big shout out to our CME organizing team, management, Kasturba Hospital, and everyone involved in making this CME a resounding success. Finally, I want to thank our delegates for their active participation and engagement throughout our sessions. We will be having an alumni meet for all our KMC Manipal alumni at the Luminaire Hall in the Fortune in Valley View Hotel. I request all our alumni to join us there tonight at 7:30 p.m. We would also like to extend our gratitude to Dr. Alex Joseph from Changi General Hospital, Dr. Suresh Paranjyoti from National University Hospital, Singapore, and Singapore Critical Care Society for their support for the POCUS workshop. The website pocus.sg developed by them was extremely helpful in preparing the delegates for the workshop, and we thank them for granting free access to multiple aspects of the website such as videos, tutorials, and MCQs. Also, for the delegates taking part in the workshop tomorrow, I request you to come to TMAPI Hall 2, which is in the second floor, for breakfast, which will be served from 7:30 a.m., from where you will be escorted to the respective workshops by 8:30 a.m. Kindly remember to wear your respective tags, as they will serve as your identity for the workshop groups. Lastly, delegates, please collect your CME certificates at the registration desk on your way out. Certificates for the workshop will be distributed separately after the workshop tomorrow. Thank you and wish you all safe travels. Reminding again for the alumni meet, which will be happening today at 7:30 p.m. at the Luminaire Hall in Valley View Hotel.